My name is Faheem Sandhu. I'm Director of Spine Surgery in the Department of Neurosurgery at MedStar Georgetown University Hospital. I specialize in the treatment of minimally invasive approaches to spinal disorders that affect all parts of the spine and spinal cord, from the neck, the middle of the back, and the lower back. And this basically involves making smaller incisions, splitting through the normal musculature, so we preserve as much of the normal anatomy and structures, but still achieve all of the goals of surgery in terms of decompressing the spinal cord or nerves and stabilizing the spine if we need to do a fusion procedure. I would say 85% of what I do surgically is amenable to minimally invasive techniques. At MedStar Georgetown, we have a number of tools that allow us to treat both complex and straightforward spine problems. And I think you need that breadth of techniques to really cover the full gamut of spinal problems. I really love my job. I think it's gratifying to help people that are in pain and or have disability and allow them to be pain-free and recover from their weakness and disabilities. And to me, it's a very exciting field. It's evolving. We're doing new techniques that allow us to treat problems that we hadn't been able to treat as effectively in the past. And I'm constantly rewarded by seeing my patients do well, and that certainly keeps me motivated. I think what we offer at Georgetown is the ability to treat the maximum number of problems that affect the spine using minimally invasive techniques, because we're familiar with all of the techniques and how and when to use them. I think done for the right reasons and done with the right techniques, people can have excellent outcomes from surgical intervention, and it can be life-altering and take someone who was not walking to being pain-free and walking and really returning to a normal quality of life. We differ in our background in terms of training, and orthopedists work generally with bones or in the body, throughout the body, including the spine. Neurosurgeons deal with the brain, spinal cord, and all of the nerves, and so there is an overlap between those two specialties when it comes to working on the spine. And historically, the orthopedic surgeons would do a lot of the bone work or deformity correction, and neurosurgeons would work closer to the spinal cord and nerves, and oftentimes we shared those responsibilities and surgeries and did them together. However, I would say in more recent times that those boundaries have blurred, and now there's almost a common specialty of spine treatment, and I think a good orthopedist or a good neurosurgeon specializing in the treatment of spinal disorders do very similar work. Back pain is one of the most common ailments that affect people, and either one of the number two on the list, I believe, of reasons people seek medical attention. But the majority of these people, probably greater than 90%, don't need any significant intervention. But people who have persistent pain, it just doesn't go away with the normal over-the-counter medications or a short course of physical therapy, they probably need to be seen by a specialist. And certainly if they have any pain which radiates into their arm or leg, that suggests compression of a nerve and warrants a little bit more attention. It is a different approach to treating common disorders of the spine, and it involves basically preserving tissues by splitting through muscle instead of making big incisions and stripping the muscle off of the bone, which usually devitalizes the muscle, especially in the lumbar spine, and affects the function long term, and also may affect the need for additional surgeries long term. So with minimally invasive procedures, we're able to make smaller incisions, focus on the area of the problem or pathology in the spine, and we split through the muscles. So when I take out my retractors, the muscle comes back together and functions better, and the recovery is faster, blood loss is less. Most common spine problems can be treated using minimally invasive techniques. So starting with problems in the neck, disc herniations can be treated using minimally invasive procedures, coming either from the back of the neck, making a small incision, splitting through the muscles, and decompressing the nerves, even removing small disc fragments that way. Certainly in the thoracic spine, we can treat disc herniations in a similar way. Even tumors have been treated using minimally invasive techniques of the spinal cord or the spine. And in the lumbar spine, I think we've seen the most significant advances, and that's the most common area where we do minimally invasive procedures, and that involves doing simple surgeries like disc herniations, or treating stenosis or compression of the nerves, either at one or multiple levels, through small incisions, which allows me to do surgery on much older patients. So people even in their late 80s or 90s, I've operated on people in that age range, are eligible for surgery, whereas with a bigger surgery, bigger blood loss, more recovery, they're really not good candidates for surgery. But using minimally invasive techniques, it really opens up a spectrum of opportunities for patients that may not otherwise have been considered surgical candidates. And then now we're also doing all the common spinal fusions using less invasive techniques, muscle splitting, and that includes placing pedicle screws and doing fusions at 1 or 2 levels, all with minimally invasive techniques. No, it really requires specialized training either during fellowship or extended courses to really learn and then master these techniques. But someone who's made the commitment to do that certainly would be capable of doing that with either a neurosurgical or orthopedic background. I do not use a laser in any of our techniques of minimally invasive procedures. Laser had been used a number of years ago for some forms of discectomy. Those types of discectomies actually were shown to be less effective in long-term outcomes, and most people have gotten away from using any laser for these common procedures. The key to minimally invasive approaches is not the use of a laser or marketing the use of a laser. It's really preserving the anatomy, splitting through the muscles, and then accomplishing the same surgical goal that you would do in an open manner. We're just getting to the spine in a much less disruptive manner. So one of the newer techniques that I've been utilizing in treating lumbar stenosis or compression of the nerves is a technique of introducing a shaver under the facet joint, which will allow us to decompress the nerves not only in the spinal canal, but the ones that are coming out of the spinal canal. And traditionally, a lot of these people, because of the bad compression of the nerves in both areas, we would totally decompress the spine, remove those joints, and that would necessitate doing a fusion afterwards because you've taken away so much bone that the spine is no longer stable. With this device, it's called IOFlex, made by a company named Baxano. You introduce a wire that goes under the joint. You confirm that it's in a safe place above the nerve using neuromonitoring. And then we basically, just like a nail file, shave the undersurface of that joint, and that creates a lot more space for the nerve. I think I've avoided doing some fusions in that manner, and patients have done very well in terms of resolution of their back and leg pain following this procedure. It's a way of getting to an area that is very difficult to get to surgically without removing all of that joint. And it's really the undersurface that you have to clean out. And the instruments, the traditional instruments that we have, are not very effective at reaching out underneath the bone and the joint to properly decompress the nerves. But this technique really allows us to do that and still preserve the joint and its function. Older patients with back pain radiating down the leg, they've failed treatment with physical therapy, with injections, and now they need surgery, and they have on their x-rays and MRI scans clear evidence of compression of the nerves, not only in the spinal canal, but in the outlets of the spine, where the nerves come out of the spine. And I think they're the ones that are best suited for this treatment. And then even some people with what's called spondylolisthesis, or a slippage of the vertebrae. And that's not an uncommon problem to see as people age. You get a little bit of slippage as the spine degenerates. Sometimes that's associated with clear instability, where the spine, those vertebrae move. And in those cases, we recommend doing a fusion in addition to the decompression procedure. But many of those people, they have the slippage, but it's stable and it doesn't move. But when the bones slip like that, it narrows the outlet spaces for the nerves. And getting the shaver underneath allows us to open up those spaces without needing to fuse the spine, because there is no clear instability there. And by also preserving the normal muscles and ligaments, we're not destabilizing the spine further. So I think a lot of these people do very well long term, because we're preserving all of those structures and we're not creating instability. We're just decompressing the nerves, treating the underlying problem, and they get improvement in both their back and leg pain. Spinal fusion is a surgical treatment where we join two vertebrae together, or more than two vertebrae together. And long term, it's bone that heals and joins those together, and temporarily we use screws and rods to link them together while the bone heals. And most people that require spinal fusions have some degree of deformity, like scoliosis, curvature in their spine, or instability where two vertebrae are moving relative to another. And sometimes people who have tumors or trauma also require spinal fusions to stabilize their spine if there's instability or fracture. Those are probably the most common reasons. Certainly minimally invasive techniques are used to achieve spinal fusions as well. I've been doing single level fusions using a minimally invasive technique called a transforaminal interbody fusion, and we place pedicle screws as well as cages in the disc space, and that can be done through a 2.5 centimeter incision. Another technique that we use is coming in from the patient's side. It's a lateral interbody fusion where we clean out the discs and go through the psoas muscle, which sits on the side of the spine. And that's a very useful technique for treating patients with deformity or even slippage of the spine. And then certainly in the thoracic spine, we can perform fusions by placing pedicle screws in a minimally invasive way with guide wires and needles and through small incisions, and that's been very beneficial to some of our patients. In my experience, most people recover faster from minimally invasive surgeries because we're just splitting through the muscles, and so generally the hospital stays are shorter. They average 2 to 3 days versus 4 to 5 days with the traditional techniques. After a single level spinal fusion, there's no reason to expect that you couldn't do everything you wanted to do, even if you wanted to continue athletics and many of the normal activities that you enjoy. I think once the bones have healed and you've recovered maximally, all of those things are possible. The majority of our techniques still require general anesthesia, but the risk of needing blood transfusions, the amount of blood loss, the length of the surgeries, that's certainly decreased with some of these procedures. And I think that's been clearly demonstrated in multiple studies and multiple institutions that these procedures definitely reduce blood loss, need for transfusion, length of hospital stay, and the need for narcotic pain medicines after surgery. The pain from a typical minimally invasive discectomy, where we make a very small, less than 1-inch incision, split through the muscles, and work through a tubular retractor, that can be pretty minimal for some people. And I've had patients who stopped taking pain medicine within 3 days of their surgery. Yes, I think the nice thing about using these techniques is that it allows us to be less disruptive, and the majority of my patients who I perform discectomies, also decompressions for lumbar stenosis, and sometimes decompressions in the neck from the back, all can go home the same day. And many of those people are off narcotic pain medicines within a week of surgery. You may need to wear a brace after your spine surgery if you've had a multi-level fusion that spans many levels in the spine. Generally for 1 or 2 levels of fusion in the spine, I think it's unnecessary to wear a brace, and the screws and the rods that we place serve as an internal brace and are adequate. One of the more dramatic areas that I've seen minimally invasive surgery affect my patients is certainly the people that were just considered not surgical candidates at all because they have a lot of other medical problems, they're just too sick, or they're too old, and people just considered it high risk to do a surgery where there'd be a lot of blood loss, a long-term recovery, and probably not a meaningful outcome. But using these less invasive techniques, you can really achieve those goals in a very reasonable manner for these people and allow them to enjoy a much higher quality of life. It really depends on the underlying problem. I mean, there's certainly some of the more complex deformity surgeries. We're still evolving what's the best approach in terms of using minimally invasive techniques, and I certainly have used them for some problems, but like degenerative scoliosis in older people. But we want to achieve the best outcome, and if that's at all, if I feel it's going to be compromised by using a minimally invasive approach, then I will elect not to do that. Or sometimes we can combine one technique with an open technique and still decrease blood loss or improve certain aspects of that surgery by combining the techniques. Even in the spine community, there were thoughts that, especially with minimally invasive spinal fusions, that the fusion rate would not be as good, or the outcomes would not be as good. And I think that has not held out. I mean, certainly, if one is meticulous and pays attention to all the necessary details while they're doing the surgery, fusion rates are quite high. And in my practice, that has not been an issue at all. And certainly in our literature, that is not held true either. So I think some of the concerns, even in the surgical community, about the downsides of minimally invasive surgery have not borne out. Well, I think the key to a healthy back is always prevention. And I think the things we have in our control are probably three things. One is, I would say, do not smoke. And if you do, you should stop, because cigarettes damage not only the lungs and your blood vessels, but your discs in your spine, and create degenerative changes and accelerate those. So that's number one. Number two is maintain your weight, so you don't get overweight, and stay fit, and regular exercise to keep your core muscles strong, your back and abdominal muscles. And I think those are the three things that we have in our control. You can't control your genetics or sometimes your environment, but I think a little bit of prevention goes a long way. So. Certainly, I think it would be worth reconsidering what can be done for your spinal condition, because the techniques have evolved certainly over that time period. And it may be that there are newer techniques that would solve the underlying problem better. Well, I spent a year learning these techniques with one of the gurus who helped pioneer the field in Chicago. And during that time, we were really helping develop these techniques. I really felt like I was in the kind of the epicenter of a new field being started, and it was very exciting. Still, to me, is very exciting to be part of an evolving field.